Hello and welcome back to another episode of the Birth Serenity podcast. Remember that you can also watch and listen to all our videos and episodes on YouTube, Facebook or IGTV, and of course on the podcast platforms Spotify and Apple Podcasts. Please remember to like and share these videos with all your pregnant friends or just give us a good rating on the podcast platforms. So last week we had Dr. Rachel Reed on the show, and she is back this week to talk about big babies, another scapegoat that so many care providers use to get mothers into having pre-labor cesareans. If you are pregnant and you are told that you are expecting a big baby, or maybe you are still very early in your pregnancy, but your doctor is already telling you that your baby is measuring way bigger than it is supposed to, then this episode is definitely for you. My name is Carla Nivout and I am extremely passionate about pregnancy, birth and babies and helping you to find your way through and embrace both the messy and magical things on this extraordinary journey of bringing your precious baby into this world. I'm a small-town mama who has taken a leap and become a certified birth educator and have a very deep desire to help as many mothers as I can around the world. I want you to feel ready, confident and excited to go into labor so you can have your best chance at a smooth, calm and a beautiful natural birth. So please get comfy and ready to learn all you need to know to feel prepared and informed about your pregnancy, birth and easing into breastfeeding with confidence. We won't shy away from the real talk. This is the Birth Serenity podcast. Okay, so now let's talk about big babies. This is another scapegoat that care providers use. So what factors influences the size of babies?
The mother who they're growing in. So it could be genetic, this might be a family. So women actually alter the size of their babies. So if you had a huge partner, for example, with genetics for a big baby, it's the environment in the uterus that alters the growth of the baby. So a woman's not going to grow a baby that's too big for her. So genetics influences the size of a baby, the mother's genetics, the health of the woman. So, healthy women tend to grow big, healthy babies. In my experience of practicing, it was very different when I worked with very disadvantaged women who, were unable to really be healthy. And a lot of them smoked. They were all small babies. And then when I started working in private practice, because in Australia, which means then this is women who can afford to pay for a midwife. So these are well-resourced women who are, thinking about their health because that's why they're choosing a home birth. All of the babies were 4 kilos or over. It was like just so normal for it to be a big baby that, 4.6, then it was big, but 4 kilos was was normal. So it's basically about the environment the baby's growing in as to whether it's going to get big or not. There's a complication in pregnancy, which is high blood glucose levels. That can grow a bigger baby than is, ideal for that woman. And that's about how when a baby is getting additional blood glucose through the placenta, then they increase their insulin production, and that insulin kind of captures all of that blood glucose, turns it into fat, and the fat tends to be right up at the shoulders and at the top part of the baby. So it doesn't make the baby skeleton bigger, but it makes the baby fatter, and it makes the distribution of fat up at the top end of the baby.
Yeah. And also gestational diabetes, if you're diagnosed with that.
Yeah, well, you see, it's a bit of a question as to whether it even exists. So gestational diabetes is a label that we give to women, and often when we change the parameters. So we've got, in Australia, we've got around 18% of women are diagnosed now with gestational diabetes, but it's not the label that's the problem. If a woman has high blood glucose levels in pregnancy, then it alters the growth of the baby. If she doesn't, then it doesn't. So even if she's been told she's got gestational diabetes, if her blood glucose levels stay normal through the pregnancy, then she is not going to grow a bigger baby. She's not going to have the risks that are associated with gestational diabetes, because it's not the label, it's whether or not your blood glucose levels are too high.
Mm-hmm. And also that can be managed by a better diet.
Yeah.
So
you
just have to look better after yourself then during pregnancy if you get that label. Is an ultrasound accurate when it comes to estimating the size of a baby during pregnancy?
No, not at all.
Short and
So it's
sweet.
Yep. So it's actually inaccurate by about 15%. So you can't estimate the size of a baby from an ultrasound scan. That's like, it's known, that's been researched. So I don't know why we keep doing it. I don't know why this still is a thing that seems to be trotted out. The only way to know the size of a baby is to wait until it's born and measure it. That's the only
Yeah.
way.
And 15% is a lot. If the doctor estimates a baby at 4 kilos, 15% is only a 3.4 kilo baby.
Mm. Yep.
Yeah, that's 600 grams.
Yeah, it's a big difference.
A big difference, yes.
Mm-hmm.
Research suggests that the complications associated with big babies may be due to interventions carried out when a baby is suspected to be big and not actually by the size of the baby. Explain this to our mothers listening.
Yeah, well, this is really interesting, isn't it? So there is lots of research about, how dangerous big babies are. And what that research has shown us is that the research, the common research that's trotted out is the research that says if you have a big baby, you're more likely to have a shoulder dystocia and you're more likely to have perineal tearing, which would make sense because the baby's bigger. However, if you look at the research that kind of looks at babies that were perceived as being big versus babies that actually are big, then we see a different picture. So for women who just have a big baby that nobody anticipated, they're not at risk of these additional tearing and shoulder dystocia and the complications that we associate with big babies. Whereas women who have been told they're having a big baby and their care provider thinks they're having a big baby, even if that baby's not big, they are at increased risk of having those complications. So there's something about how care providers perceive the size of the baby and then what they do about that is influencing birth outcomes, not just the size of the baby.
Let's say at 20 weeks, your care provider now starts telling you, because that's normally when they start planting the seed. Okay, now
At
your
20
baby.
weeks.
Yeah, then they tell the mothers
Wow.
you are 20 weeks pregnant now, but your baby already measures 22 weeks. So you'll have a really big baby. And do you think it's just better to then tell your care provider, so when I come for my next checkup, please, I don't want to know the size of my baby. You can just tell me, yes, baby is healthy, baby is growing, but I don't want to know the size or what you think of it. Do you think that'll be a better call?
It will, but if the care provider knows, then how they care for you will be different. So, for example, I was looking after a woman that I actually didn't know because it was a hospital birth. So I just got handed over. There's a woman in their block. And the handover to me was, this woman's got a really big baby. So you must get the obstetrician in there when the baby's born. All of this fear stuff. And I went in the room and this woman was scared as well because she'd been told she had a big baby. So the whole story around this was a risky birth and a big baby. And it took the woman a bit of time to kind of just let herself relax into the labour because she was worried about it. And then when she started to push the baby out, she was actually in the toilet. So that's where she was pushing the baby out. And the obstetrician must have heard her pushing the baby out because as the baby came out, I looked up and there's an obstetrician in the doorway. And I kind of shooed them away as the baby was born and they went out. And then after that, I went out of the room and I was absolutely told off because how dare you have her birthing in the bathroom? If that baby had got stuck, blah, 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 we needed to have her on the bed as agreed to birth the baby in a position where we could manage it, completely ignoring the fact that this baby was actually a normal sized baby, 3-point-something kilos, and had birthed perfectly fine. But there was all this fear that was around her labour and birth that didn't need to be there. And if I'm guessing I had done what I was meant to do, I would have been getting her on the bed and reducing the chance of this baby coming out. Because once a woman's on her back on the bed, then it's not easy for babies to come out in that position,
Yeah. Oh no. If a mother is really focused on having a natural birth, but her baby is labeled as big, is induction a good idea? Because that's the next thing then that they'll start telling mothers we need to induce at 39 weeks or max 40 weeks, but you can't go 41 weeks because baby is way too big. So yeah, what do you think of that induction and using big baby as an excuse?
Well, again, the kind of research-based guidelines do not support inducing based on an estimated size of a baby. It's not recommended by obstetricians, never mind, midwives or anybody else. So if that's being suggested, then it's going against world research-based guidelines. Induction increases the risk of shoulder dystocia, which is the thing you're trying to stop happening. And it's not a natural birth. So what happens with induction, with the contractions? So when you're having a physiological spontaneous labor, your body regulates contraction patterns. And you'll see that when the baby, you've probably seen it yourself, that when the baby's in that phase of coming out, of navigating through the placenta, there's often a big space between contractions that give the baby the opportunity to rotate their shoulder and get their shoulder lined up to come through the pelvis. With induction, you've just got really standardized contractions happening all the time, and the baby has got less opportunity to wriggle into a good position to get through the pelvis. So inducing labor increases the chance of a shoulder dystocia itself. So that doesn't make sense to then offer it to reduce the chance of shoulder dystocia. So induction is not, it's not a rational way of dealing with a guess about the baby's size, which you can't even estimate accurately anyway. So I would say if you want a natural birth, then induction isn't a natural birth. It's very, very different. Even if it's a vaginal birth, it is a very different experience. It's not physiological contractions. So yeah, have a think about that.
So as long as your amniotic fluid levels are perfect and you feel fine and baby is fine, induction is never a good idea, right? Even if you're 42 weeks.
I would never say anything is a good idea or not a good idea. So the way that I work with women and as a midwife is it's my job to share information. It is not my job to make recommendations or make decisions. I might make a recommendation if there's a complication versus a variation. So when there's a variation, it just means that women have gone outside of the norm, which most women will do, but there's nothing currently risking the woman and the baby. There's not an actual thing happening now that's putting them in danger. So that's things like, I don't know, post-dates pregnancy. It's a variation, it's not a complication. Versus a woman who's got preeclampsia and has symptoms, then I would be recommending induction because you're having a complication that needs medical intervention versus you're just not fitting the norm. And this is a variation and a healthy variation, then it has to be up to the woman to make those decisions. So you talk about what the options are, what the risks and benefits of each of the options are, what she feels like she wants to do, if there's any more information she needs, and then you support that woman's decision regardless because it's her body and it's her decision.
Yeah. So just to summarize this big babies thing, yes, in very short, what would you tell mothers who are being told your baby's too big? You cannot have a vaginal birth, baby is way too big.
1, you have no idea how big the baby is. 2, women birth big babies all the time without problems. Your problem is other people's perceptions. That's what I would say.
Thank you, Rachel, for your time and for everything that you do for the birth industry and for pregnant mothers. I love reading your blog. I love all the work and the research that you are doing. I love that you support mothers' wishes. That is everything that we stand for here at Birth Serenity. So thank you so very much for taking the time and sharing all of this very valuable information with us.
Oh, thank you. And thank you for the work you're doing. It takes lots of us doing it in lots of different directions to change this.
Yeah, we need to get the right information out there, right?
Yep, absolutely.
Are you pregnant, hoping for a smooth, calm, beautiful natural birth? Let us help you with that. In the Birth Serenity Antenatal Program, we focus on natural birth and would be honored to help and support you to prepare yourself in the best possible way, both mentally and physically for your birth. Our aim is to help you find peace and accept your birth whichever way it turns out. For more information, go to birthserenity.com.